I'm Dr. Sana Rasheed. So today I will be teaching about respiratory system. So a bit about myself. I am basically a GMC registered doctor currently working in UK as a junior clinical fellow in general medicine. And I have given this exam, MRCP Part 1 recently. We'll be starting with the respiratory system, which is one of the most important system, and it has a quite a weightage in the exam as well. So today we will be discussing the anatomy and the physiology of the respiratory system along with the obstructive lung diseases. So I'll try my best to cover all these topics in this class, starting with the anatomy of the respiratory system. As we can see in this diagram, the respiratory system basically consists of all these organs and or parts. So broadly, we classify the respiratory system into upper respiratory tract and a lower respiratory tract. If we talk about the upper respiratory tract, that basically includes the nasal cavity, the pharynx, the larynx, the trachea. And then we have the lower respiratory tract, in which we have the lung parenchyma, the bronchi, and the bronchioles, and basically this airways. So through breathing, inhalation, and exhalation, the respiratory system facilitates the exchange of gases between the air and blood, and between the blood and body cells. The respiratory system also helps us to smell things and create sounds. Now we're going to discuss the key 5 functions of the respiratory system. So one more thing that I want to add is that whatever I'm going to discuss from the anatomy and physiology is going to be things that are going to be related clinically as well, because as an MRCP, we do not get very detailed questions regarding respiratory system anatomy. So it's mainly the anatomy and the physiology that is linked to the pathology or the diseases that you guys need to know. That is the reason we are not going to go into very detail of the anatomy particularly, because it is more important for surgery as compared to physicians. So yeah. In pulmonary ventilation, air is basically inhaled through the nasal and oral cavities that include the nose and the mouth, and then it moves through the pharynx, the larynx, the trachea, and then into the lungs. So basically, the air enters through this tract, and then it leaves through the same pathway. The changes to volume and air pressure in lung is going to trigger the pulmonary ventilation. So what happens is that during normal inhalation, when we take air in, the diaphragm and external intercostal muscles, they contract, due to which the ribcage elevates. As the ribcage elevates, the volume of the lungs increases, and the air pressure is going to drop within the lungs, due to which the air is going to move from the airways to the lungs, from a high pressure area to a lower pressure area. And then during exhalation, these muscles that were contracting before, the diaphragm and the external intercostal muscles, they are going to relax. So when these muscles are going to be relaxed, the air is going to be expired. Moving on, if we talk about lungs, the oxygen is basically exchanged for carbon dioxide waste through the process that is called external respiration. These are basically the basics for the respiratory system. This respiratory process takes place through hundreds of millions of microscopic sacs called alveoli. Oxygen from inhaled air diffuses from the alveoli into the pulmonary capillaries that is surrounding them, and then it binds to the hemoglobin molecule in the red blood cell and is pumped through the bloodstream. Meanwhile, the carbon dioxide from the deoxygenated blood diffuses from the capillaries into the alveoli, and it is expelled through exhalation. And then the blood is basically involved in the delivering of oxygen to different organs, and it removes carbon dioxide through internal respiration. In this respiratory process, red blood cells carry oxygen absorbed from the lungs around the body through vasculature. When oxygenated blood reaches the narrow capillaries, the red blood cell releases the oxygen. It diffuses through the capillary walls into the body tissues. Meanwhile, the carbon dioxide is going to diffuse from the tissue into red blood cells and plasma. If there's anything that's not clear, you guys can stop me. And at the end of the session, I'll also give you time for any questions or queries that you have in your mind. All right. So now they've talked in detail about the upper respiratory system. As we have discussed earlier, it consists of nose, the nasal cavity, the pharynx, and the larynx. The upper respiratory system is very important for breathing as well as speaking. So this, as you guys can see in the diagram, is the upper respiratory system. They warm and clean the air that we inhale. The mucous membranes lining the upper respiratory tract is going to trap the foreign particles, including smoke and other pollutants, before the air travels down to the lungs. This is another function of the respiratory system, which is olfaction. So I'm not going to go into the detail of it. It's mainly basically because this is not as such included in the respiratory system. All right, so basically, if we talk about sinuses are also a part of respiratory system. So we have frontal sinus, ethmoid sinus, sphenoid sinus, and the maxillary sinus. The mucosa, they line these paranasal sinuses, and their function is basically to warm and humidify the air that we inhale. So when the air enters the sinuses from the nasal cavities, the mucus formed by the mucosa, it drains into the nasal cavities. Now, the pharynx or throat is shaped into a funnel. What happens is that during respiration, when we basically breathe, it conducts air between the larynx and trachea and nasal cavities, oral cavity. Pharynx basically has three main parts. The upper pharynx, the one that is present posterior to the nasal, this is the nasal cavity. The part of pharynx which is present posterior to the nasal cavity is the nasopharynx. Then we have the part of the pharynx which is present posterior to the oral cavity, which is basically the oropharynx. And then we have the laryngopharynx. This is the part of the pharynx that is present posterior to the epiglottis, and it basically connects the esophagus with the larynx. So the nasopharynx is posterior to nasal cavity and serves only as the passageway for air. The oropharynx lies posterior to the oral cavity and contains palatine tonsils. And both air and ingested food is going to pass through the oropharynx and then through the laryngopharynx below. Laryngopharynx lies posterior to the epiglottis and connects to larynx and esophagus. So as we breathe, the epiglottis stays up and air passes freely between the laryngopharynx and the larynx. Right? So it's very important that during breathing, when we're not eating, the epiglottis is going to stay up, right? So epiglottis has its role in preventing aspiration while we are eating, because when we eat, what happens is that the epiglottis covers the larynx to prevent the food going into the cavity. So this is basically the epiglottis. Now, the larynx connects the lower part of the pharynx, the laryngopharynx, to the trachea. It keeps the air passages open during breathing and digestion and is a key organ for producing sound. And the larynx itself has 9 cartilages. So these are basically the cartilages of the larynx. Now, epiglottis is a lifesaver. So as I've told earlier, look, it is located on the posterior side of the larynx. The epiglottis closes like a trap door as we swallow. This section steers food down the esophagus and away from the windpipe. Inside the larynx are the vocal cords, which have elastic ligaments at the core. And when we speak, yell, or sing, the air coming from the lungs and the trachea vibrate to the folds due to which the sound is produced. So this is very basic thing that larynx has vocal cords in it, which is responsible for sound production. Phonation is the creation of sound by structures in the respiratory tract of the respiratory system. During exhalation, the air passes from the lungs through the larynx or the voice box. And then we have structures called arytenoid cartilages that push the vocal cords or the vocal folds together. So whenever the vocal cords are pushed together, the air passing through them is going to vibrate, that is going to create a sound. Greater tension in vocal cords creates more rapid vibrations. As a result, higher which sounds are produced. And when the tension is low, lower vibrations are produced. As a result, the pitch of the sound is going to be low. Then we have this bone that is known as hyoid bone that is located in the chin. Now, this bone is basically a very important contributor to both the respiratory as well as the digestive system. It is the only bone in the body that it does not touch any other bone, because here we have this membrane and then it is attached with the ligament. The hyoid is attached to tongue and helps you to swallow at the start of digestion. And in respiratory system, the structures that produce sound depend upon hyoid bone. Okay, so these are basically the details of the olfaction, which, okay. So the respiratory system in close conjunction with the circulatory system is responsible for supplying all body cells with essential oxygen. It removes potentially harmful carbon dioxide from the body. The mouth and the nose channel air from outside the body through a system of tubes of diminishing size that eventually reach two lungs situated on the side of the, okay. So this is basically the anatomy of the main respiratory system, right? So if we talk about this is basically the trachea. So trachea divides into two main bronchus. This is the left main bronchus, and this is the right main bronchus. If we talk about the right main bronchus basically gives further three bronchioles, and that basically divide further. Okay, and the right lung basically has three lobes in it. This is very important clinical. It's basically a very important clinical correlation, because when we are going to discuss about pneumonias and abscesses, so we always see that which lobe is affected. So the right lung has three lobes, while the left lung only has two lobes in it. So this is the apex of the right lung. Then we have the superior lobe of the right lung that contains three bronchopulmonary segments. Then we have the inferior lobe and the middle lobe, right? So this is basically the horizontal fissure. Horizontal fissure separates the superior lobe from the middle lobe. And then we have this oblique fissure here that separates the middle lobe from the inferior lobe. Inferior lobe, basically, the main part of inferior lobe is can be auscultated from the back of the chest rather than the front, because as we can see from the front of the chest, it's just this part of the inferior lobe that is visible. And then we have the terminal bronchioles. Terminal bronchioles are basically tiny bronchioles, right? And what they is they further subdivide into respiratory bronchioles, and respiratory bronchioles are the one that lead to the alveoli. So if we talk about the respiratory unit, the basic unit at which the breathing takes place, so it's basically the alveoli, the respiratory bronchiole, right? Similarly, the left lung has an upper lobe and a middle lobe, and then we have a fissure in here as the oblique fissure that basically divides these two lobes here. So yeah, so here they've basically discussed the and it's a detailed diagram of the respiratory airways. We have the trachea, the right main bronchus that is dividing into the secondary bronchus, then that divides into tertiary bronchioles, and then what we have is the respiratory bronchioles that supply the alveoli. So here each color indicates an individual bronchopulmonary segment, which is irradiated by a tertiary or segmental bronchus. And then what we have is the alveoli. So as I've already discussed, that the terminal bronchiole is going to further divide into the respiratory bronchioles. And then these respiratory bronchioles go and open into alveoli. And these alveoli are basically supplied by a rich capillary bed, and they are there for the gaseous, this blood is there for the gaseous exchange. The oxygen is going to move from the alveoli into the blood, and carbon dioxide is going to move from the blood to the alveoli. So I'm just going to quickly read it. The lungs, microscopic air spaces, alveoli are elastic thin-walled structures that are arranged in clumps at the end of respiratory bronchioles. They resemble bunches of grapes, although the alveoli are partly merged with each other. White blood cells, known as macrophages, are always present on their inner surface where they ingest and destroy airborne irritants. Around the alveoli are networks of capillaries. Oxygen passes from air into the alveoli into the blood by diffusion through the alveolar and capillary wall. So the process through which the oxygen moves from the alveoli to blood is diffusion. We are going to discuss the details of this process in the physiology. Carbon dioxide diffuses from blood into the alveoli. There are more than 300 million alveoli in both lungs that provide a huge surface area for gaseous exchange. And here they've discussed about the alveolar wall. So the alveolar wall is only, it's a very thin line structure. The reason for that is an effective gaseous exchange. They should collapse inward like a deflated balloon due to powerful surface tension in their fluid lining. Their collapse is prevented by a natural substance with detergent-like properties, also known as surfactant. So basically what they're saying is that alveoli are like balloons. They have this surface tension, right? If there would be no surfactant, what would happen is the alveoli, they would have collapsed. And that's exactly what's happened in premature babies that are born in which there's inadequate surfactant, or they do not have adequate levels of surfactant. Hence, the alveoli do not open up properly and they basically go into respiratory distress. So surfactant is very important to keep the alveoli open. It is produced by the alveolar cells and consists mainly of the fatty substances such as cholesterol, phospholipids, and proteins. Besides keeping alveoli inflated, it prevents a role in disabling bacteria, which prevents certain lung infection. So so they have basically told us that this is the alveolar wall, which is basically collapsing in the absence of surfactant. And with surfactant, the wall gets stable. So that's all we need to know for our, Okay. So that was basically, I would say this was the main anatomy. If any of you have any questions, you can ask me. Otherwise, we'll proceed with the respiratory physiology, which is much more important than anatomy. All right. So I'm assuming the things are clear on your side. So we'll just proceed with the respiratory physiology. So in respiratory physiology, we'll start with the mechanics of breathing. Then we'll discuss about the gaseous exchange, the oxygen hemoglobin curve, and lung volumes, the pulmonary function test, all of those things. And these are much more important from an exam point of view as well, because there are many conditions and diseases that are linked to the physiology, of course, where the physiology is going to go wrong. So starting with the mechanics of breathing. So as we have already discussed, that a breathing cycle consists of an inspiration and expiration. So in mechanics of breathing, we have the muscles of the inspiration and muscles of expiration. Muscles of inspiration. If we talk about the muscles of inspiration, the most important muscle for quiet inspiration when we are resting and breathing is diaphragm. External intercostal muscles and accessory muscles are not used in quiet breathing. We only use these muscles when we need an extra, basically when our body demand is greater, which is an exercise or respiratory distress. Otherwise, when we are sitting, when we are in our routine breathing, diaphragm is the most important muscle that is being used. But whenever it's needed during exercise, the external intercostal muscles and the accessory muscles, they also take part. Now, coming to the muscles of expiration. If we talk about expiration, expiration is a passive process. Usually, lung itself, the chest wall is elastic and it returns to the resting position after inspiration. So there's no muscle involved in a quiet expiration. But when we are exercising or in certain conditions such as asthma, where the airway resistance is increased, abdominal muscles and intercostal muscles can be used in expiration. Moving on to the next concept, which is the lung compliance. So what is a lung compliance? It's basically the change in the volume of lung per unit change in air pressure. The ease at which the lungs and thoracic wall can be expanded, or you can say the distensibility of the lungs and chest wall. So basically, the more compliant is the lung, that means the lung is easy to inflate, it's easy to breathe. And the lung compliance is inversely related to the stiffness and elastance. Basically, what they're saying is, if the lung is going to get stiff, the compliance is going to go low. So the stiffness and the lung compliance, they are inversely related. Okay, so if we talk about the high compliance, and okay, so there are certain factors that increase the compliance of lungs, and there are certain factors that decrease the compliance of lungs. With age, what happens is that lung compliance increases. And then there are certain medical conditions that also increase the compliance of the lungs, that is emphysema and asthma, right? So what happens is that basically the lung wall, the lung parenchyma expands easily due to loss of alveolar wall and associated elastic tissue. So in emphysema, what happens is that there's loss of the lung parenchyma, due to which it gets easier to inflate the lung. Similarly, with surfactant therapy as well, if we give surfactant to any patient, any person, their compliance is going to go up. On the contrary, there are other conditions that decrease the compliance of lungs, such as pulmonary edema. In pulmonary edema, the fluid is going to fill the alveolar spaces, the alveoli. And when there will be fluid within the alveoli, so alveoli are not supposed to contain fluid. They are supposed to have gas in them, the oxygen and the carbon dioxide, because it is a place where gaseous exchange takes place. But if it gets filled with fluid, the lungs compliance is going to go low. Similarly, with pulmonary fibrosis, the lung compliance decreases with pneumonectomy or loss of surfactant. Talking about the surfactant is basically a substance that lines the alveoli. Whenever surfactant, what it does is it reduces the surface tension. So when the surface tension is going to go low, what happens is it prevents collapse and increases the compliance. So this is the main function of surfactant, to prevent alveolar collapse and to increase their compliance. And where do the surfactant come from? It is basically produced by type 2 alveolar cells. All right. So now moving to the breathing cycle. At rest, when we are normally breathing, our basically breathing cycle is pulmonary ventilation, right? So now we are going to discuss physiology at rest, what happens during inspiration and then expiration as well. So just before we inspire air, when we are resting, what happens is that the alveolar pressure is equal to the atmospheric pressure, right? So alveolar pressure is expressed relative to atmospheric pressure, and alveolar pressure is said to be 0. And the intrapleural pressure is negative. So intrapleural pressure is basically the pressure that is present between the visceral and the parietal pleura, and it is negative, right? We can measure it by balloon catheter in esophagus. But once we start inspiring, what happens is that there is contraction of the respiratory muscles that we discussed earlier, and these respiratory muscles is at rest, it's mainly the diaphragm. Otherwise, external intercostal muscles can also take role. So when the respiratory muscles contract, basically when the diaphragms contract, the lung expands. And now before inspiration, the alveolar pressure was 0. But once the inspiration starts, the alveolar pressure drops to negative. So there's a negative intra-alveolar pressure, right? And then what happens during exercise is, along with the diaphragm, the accessory muscles also contract. So this negative intrapleural pressure gets more negative. So at rest, it was -9. During exercise, it's -30. You don't need to remember any of these values. It's just to develop your concepts. And then expiration, as we've discussed earlier, it's a passive process due to elastic recoil of chest during exercise. We do use these muscles, but during resting, we do not need to use these muscles. So this was about a basic breathing cycle. How does air move space from during inspiration, expiration? What are the pressures?